Good afternoon, everyone. My name is Kimberly Fowler. I'm the Technical Assistance and Research Director here at the National Council of Urban Indian Health. We're excited to have you on the call today for our webinar on Medicare Basics. Today we have two well-experienced speakers on Medicare that will be able to bring you information on the Medicare open enrollment, as well as information on how you can help your clients in order to enroll in Medicare. We first of all have Ms. Jolie Crowder, who is the Research and Evaluation Manager for the International Association for Indigenous Aging. She currently is serving as the Project Manager for the Senior Medicare Patrol American Indian Alaska Native Integration Grant. And secondly, you'll hear from Ray Walker. Mr. Walker has done education across the country on ethics and integrity in dealing with the unique needs of the senior population. He is currently serving on the Oklahoma Mental Health and Aging Coalition, the State Council on Aging, the ADRC Steering Committee, and the SHIP Steering Committee. So without further ado, I'd like for Jolie to go ahead and get started with her presentation. And I would like to mention that your lines are all muted. You're in lecture mode, so you will not be able to speak. However, if you have questions, please feel free to write them into the Q&A box that's located at the bottom of your panel. We will answer questions at the very end of the presentations. So feel free to go ahead and write in those questions at any point in time so that we can go ahead and start the queue. All right, Jolie, it's for you.
Awesome. Thank you. Thank you so much, Kim and Chelsea. You all are wonderful. Thank you for having Ray and I back again. For those of you who were able to participate in the Medicare open enrollment presentation that we did a couple weeks ago, if you're back again, thank you so much. We appreciate that. I did want to point out before we get started, because we have a lot of slides, and hopefully we'll be able to get through all the content today. Ray is a fabulously wonderful speaker, very knowledgeable, has lots of experience working with tribal health entities in Oklahoma. But just to let you know that there are people like Ray in every state through the State Health Insurance Assistance Program. Their level of knowledge about working with tribal health and IHS may vary a little bit, but they're all super smart folks when it comes to Medicare. So if you don't already have a relationship or know who those folks are, I would encourage you, to take a few minutes after today's call or during today's call to just Google or look up your State Health Insurance Assistance Program contact for your state and consider making connections with those folks. Ray is also the director of the Senior Medicare Patrol Program, and he wears a dual role in that. And so he does great outreach as well on consumer protection issues surrounding healthcare fraud, and so he's a double whammy when it comes to that. So thanks to everyone who has joined us today. I saw lots of folks who are typing in where they're from. It looks like we have great representation in the chat pane from really all around the country. So thank you so much to folks who are joining us today. Just to give you a bit of information, the Senior Medicare Patrol, that's the grant that allows us to be here today. So just to acknowledge the funding that we received for that grant to do work on creating resource materials and to assist with outreach to the American Indian and Alaska Native populations as part of an integration grant from the Administration for Community Living. The Senior Medicare Patrol, their mission is to train volunteers, predominantly senior volunteers, to help elders in their local communities prevent and respond to healthcare fraud. And in the instance when someone feels as if they've been scammed, they can also investigate and help make referrals and help in those situations as well. So our appreciation goes out to the S&P program and ACL for funding our project. I did want to kind of get us started to give a little bit of context. Ray really has the meat of the presentation, which is, what is Medicare? It's Medicare Basics, but we're actually going to give you quite a lot of detail today. You'll get a copy of the slides eventually so that you'll have that as well. And there's a lot of other resources and materials. So if you're just trying to get started in learning about Medicare, I think this is going to be a good foray, but it is a lot of information. Don't be overwhelmed. And I found when I first started to learn about Medicare, you just got to keep reading it over and over again and keep tapping into new resources, and eventually it'll all kind of start to make sense for you. So to give us a little perspective and context, I wanted to give you some basic kind of background information. And you all are smart, savvy folks who live this every day, so this might not be new to you. I'm sure you all know from the census that there were 5.2 million folks who identified as American Indian and Alaska Native. And you also probably know that that was up 26% from the last census, and that made the population one of the fastest growing populations, even faster than Hispanic population. You'll see a number in here at about 380,000 folks, American Indian and Alaska Natives, are 65 plus, around 7% of the population. There's a little bit of a discrepancy in the numbers depending on whether you're looking at American Community Survey data, who said there were almost 450,000 American Indian and Alaska Natives with Medicare coverage, and then the IHS data set, which uncovered about 332,000 folks who said that they were Medicare recipients. So, but we're going to go with about 7% of the population right now are American Indian and Alaska Native 65 plus. The census projects that the 65 plus population is going to double in the next 2 decades. And there's 2 factors at play. One is that they're living slightly longer, thankfully, and then also the aging of the population, which isn't unique, obviously, to Native Americans. That's happening everywhere, as I'm sure you all know and see on a daily basis. There is statistics, because there's some question about how many people really have Medicare Part A and how many have B, but there was research that's shown that around 90% of people who are enrolled in Medicare have both Part A and Part B. So there is 10% of the population that is predominantly enrolled in just Part A, but for the most part, the majority of American Indians and Alaska Natives who are enrolled in Medicare have both A and B. This is a lovely map that was created that shows you Medicare enrollment by state. And you'll see, if you look at the numbers, that the enrollment actually varies from 6 to 15%, which is a pretty big swing in terms of the folks who are enrolled. Some can be explained by an issue of whether they qualify for Medicare based on work history, which is often an issue reported in the Dakotas, where they don't have the work history to qualify. They're actually, we have looked for and have not been able to find, if you have it, please let us know, a study or data that quantifies the gap. And by the gap, I mean those who are eligible for Medicare, but are not enrolled. I did find one research study that was a few years old where they attempted to do just that, and ultimately they spent a couple pages explaining why it was so incredibly difficult. And you'll see as part of the slide, I put Medicare enrollment by state and identified this as an opportunity. And I feel like there's an opportunity that exists that if we assume that, 15% is a reasonable benchmark and work towards improving coverage and getting everybody enrolled who's eligible enrolled, then, there's work that could be done. You all in your community centers and your work that you do directly with clients probably have that firsthand knowledge and ability to look at your population and identify, a one-on-one basis, are they age eligible, are they enrolled, and if they're not, help figure out how to get those folks enrolled in Medicare so that they take advantage of all the coverage opportunities that they can be afforded. So definitely an opportunity there in terms of gaps between who's eligible and who's enrolled. Another slide that I thought was interesting as we're talking kind of in the context of Medicare and healthcare expenditures and why Medicare is so important. This is a nice slide that shows per capita healthcare expenditures, and you can see, unfortunately, those IHS per capita healthcare expenditures on the right are around $2,800 per year, and then if you look to the far left are the per capita Medicare healthcare expenditures of about $11,000. I saw figures in a couple studies that said that you can assume somewhere between 19 to 65% of the operating budgets of ITUs, the tribal clinics, come from Medicare revenue, then again, I think there's another opportunity that exists in terms of Medicare revenue. And I think you can kind of intuitively see as a benefit and as an insurance and as a benefit to your elders, the opportunities that exist in terms of really getting all the benefits that they are eligible and qualify for. Some notes, and again, I try to couch this in terms of what opportunities exist for both your clinics as well as for people, elders who have Medicare or who should have Medicare but have yet to enroll. The latest research is that 2.2 American Indians receive care from IHS. There were 2014 appropriations of $4.4 billion, and 2014 IHS budget estimated Medicare revenue of about $205 million. And I did see several IHS folks who signed into the chat pane, so feel free to correct me if you have information to add to this piece. One of the more recent studies that I could find, though, which was actually on 2009 data, showed that Medicare payments for IHS American Indians for hospitalizations alone equaled about $600 million. That's for both tribes and IHS. And so I think if you just look at the IHS budget and say, we only get $200 million to Medicare, maybe that doesn't seem huge in the context of a $4 billion budget. But the reality is that number is grossly underreported, and we're probably talking about more like $1 billion, with a B in revenue that the tribes and IHS and urban centers have the potential to recoup there. Another opportunity, there was another study where they looked at the 12 IHS areas, and they found that 11 to 19% of all IHS active user costs are paid for by Medicare fee-for-service payments. So that's a pretty significant, when you take into consideration the composition of the budgets of your clinics as well as the potential for revenue from Medicare, it's pretty significant. And as you all know, IHS budget limitations, that only around 60% of funding that is needed is actually available. And there's a quote there that talks about rationing and care, deferring and denying payment for medical services just because the money is run out. And the few previous slides are really just to lead us up to why do we think folks need to have Medicare plus utilize the services of the ITU system. Medicare benefits the system. It benefits all of the facilities who can bill Medicare now as a result of legislation a few decades ago. In this scenario, these facilities pay last, and that revenue offsets money that would have been spent by the facility and allows them to provide additional health care services. They can provide new services, enhance care, improve quality. And as importantly for our elders, there are tremendous benefits. As you could see, where the IHS could spend $3,000 per person, Medicare can spend $11,000 per person. The ITU system isn't insurance. It doesn't cover all the services, and it doesn't cover all the equipment, and it doesn't all the time cover all the medications. As we said on the slide before, it can run out of funding, and the formularies can be limited. Medicare is a great way to help pay for approved Medicare services outside of the system while still giving people the value and benefit of receiving care from the ITU systems. Just a quick list of examples of services that are covered by Medicare but aren't always covered by IHS, and that might be skilled nursing care, which is covered under Part A, hospice, dialysis. There's some acute inpatient mental health programs that are covered by Part A. It provides access to mental health services outside of the IHS system. And then there's certain DME that's covered by Medicare. And one of the folks I talked to said that in their system there's very little DME that's actually covered by by their tribal health system. So, and this is going to vary, from clinic to clinic and facility to facility, but these are just some examples of benefits that our elders can get that because they have Medicare but not IHS. So. Some things to think about, barriers for folks enrolling in Medicare. And these came from some studies as well as some research that we did as part of our Senior Medicare Patrol project. It's the belief that IHS is going to cover everything, belief that they're entitled to care, and the process, as a lot of people have seen, especially with the marketplace, is that they just don't have the desire or will or feel like they should have to go through paperwork or process or jump through hoops. There's a lot of confusion about the system. A lot of folks have never had insurance before and don't really understand the terminology, coverage, deductibles, copays. It's fair to say that confusion about the system and terminology isn't unique to the Native Americans. That's pervasive across all types of populations. Then there's just they don't know how to enroll. Costs are an issue, particularly those Part B premiums. If they're living a subsistence lifestyle, can be a challenge as well. So I think the opportunities that exist for you guys are, kind of in the middle of these lists of barriers and helping eliminate confusion, helping them understand how to enroll. And if you minimize all of those barriers or do away with those, then hopefully we can help some of those folks who really need the coverage get coverage. Just a little bit of a note about Medicare Advantage and the ITU system. From what I can understand, there's actually not a very large number of folks who are enrolled. It's 11% of American Indians versus 27% of the total population. Sherry Varner, who was on our last call, talked about some of the issues, that she's been apprised of when it comes to working with a Medicare Advantage program. A lot of times the facilities don't have contracts, and in that case, if somebody has an MA plan and you go to bill them, you might get $0 back from that MA plan, or you get pennies on the dollar based on other provider arrangements or payment arrangements. So if you're in the network, it's great. If you're out of the network, not so great. There's confusion in terms of the Medicare Advantage. And enrollment and eligibility. And one of the other issues is a lot of folks may not understand that a Medicare Advantage plan is not original Medicare, and that by signing up for that, they've essentially left the comfort, if you will, of traditional Medicare. So I'm done. I try to talk fast, because I know Ray has tons of great information there. So I'm going to go ahead and turn it over to you, Ray, if that's okay with you, and put myself on mute.
All right, sounds good. Okay, folks, as Jolie said, we've got a lot of information to cover. I will try to move through it as quickly as I can, but I don't want to go too fast. I want you to get the information to me directly, and I would be happy to help you in any way I can. And also, as Jolie said, I have a counterpart in every state there is. So if you would like to know who my counterpart is in your state, send me a message and I can provide you with that information. So starting out, let's talk about the program basics for Medicare. Medicare, as you know, most people get on Medicare when they turn 65. Medicare is also available for people who are under the age of 65, but who have been on Social Security disability for at least 24 months. Also, persons of any age who are diagnosed end-stage renal disease also qualify for Medicare. The program is administered by the Centers for Medicare and Medicaid Services. However, the enrollment for the program is handled by Social Security. Now, very quickly, because we have a lot of questions that have come up over the last couple of years having to do with the marketplace and how that impacts people with Medicare. And the good news is if a person has Medicare, they don't need to do anything with the marketplace. Their Medicare coverage covers them and they meet the criteria. They don't need to get enrolled into a marketplace plan. In fact, it's actually illegal for someone to option for people with Medicare. Medicare beneficiaries should just completely stay away from the marketplace. Now, people who, as you know, if you're familiar with the marketplace plans, the thing that the Affordable Care Act is looking for with everybody is minimum essential coverage. There are these 10 minimum essential benefits that must be covered. And so people who are on Medicare, they wonder, do they meet this criteria? If an individual qualifies and has Part A of Medicare, Part A, as you know, is the part that covers the inpatient services, then they meet the criteria for minimum essential coverage. However, there are some people out there who do not have Part A for whatever reason. Most of the time it's because they haven't worked enough quarters or enough years into the system to get their Part A for premium free. You have to have worked for 10 years and paid FICA taxes for 10 years to qualify to get your Medicare Part A for premium free. But for those people who only have Medicare Part B, which is the part that covers the outpatient services, doctor's visits, outpatient surgeries, laboratory, et cetera, those people do not meet the criteria for minimum essential coverage. So that's an important distinction. Most people who qualify for Medicare have both A and Part B, but there are a handful who do not. Now, regarding eligibility for, if a person is on a marketplace plan and they're aging into Medicare, or for whatever reason, they're now going on to the Medicare system. A lot of questions come up from people about, can I keep my marketplace plan? Do I have to switch to Medicare? If an individual qualifies to get their Medicare Part A premium free, then they really need to go ahead and get on their Medicare. If a person qualifies for premium free Part A, they can choose to keep their marketplace coverage. They don't have to quit their marketplace plan. However, they will no longer receive any of the tax credits and the cost-saving features that they had under that marketplace plan. In other words, they will be paying full premium for that marketplace plan if they now qualify for Medicare benefits. So as you can see, they're really trying to encourage people to take advantage of their Medicare benefits when they become eligible. And then as far as signing up, now if a person, I spoke earlier about people who get their Medicare Part A premium free. For those individuals who do not qualify to get Medicare Part A premium free, and the cost for 2015, by the way, for Part A, if a person doesn't qualify to get it premium free, the monthly premium for Part A is $407. So as you can see, it's pretty pricey. If a person doesn't qualify for the premium free Part A, they have the option of not taking out their Medicare and just keeping their marketplace plan. And in that situation, they would in fact qualify for those tax incentives and cost sharing. So that's an important distinction to keep in mind, is if you do have a client that can't get it premium free, they could in fact keep their marketplace plan if they choose to. Now for those people who do qualify for Medicare, they need to be sure that they are keeping track of when their Medicare becomes effective, because if they don't get enrolled in Medicare when they're supposed to, they may have a late enrollment penalty, and I'll talk about that later on in the presentation. As most people know, there are 4 parts of Medicare. The 2 first parts, Medicare Part A and Part B, are the oldest parts. Part A is what covers hospitalization and inpatient services. Part B is what covers your outpatient services, physician visits, laboratory, durable medical equipment, things like that. We'll go into more detail on those in a moment. Part C of Medicare is the Medicare Advantage plans, the HMOs and the PPOs that are out there that people can get enrolled in. They're run by private insurance companies who have now contracted with Medicare to provide all of those Part A and B covered services. Then the newest part of Medicare, which started in 2006, is the prescription drug coverage. It is also run by private insurance company who provide a pharmaceutical benefit to Medicare beneficiaries, and we're going to talk more about each one of these. Now, you might know that people who have a Part C plan, a Medicare Advantage plan, in some cases they're able to get their drug coverage through that Part C Medicare Advantage plan, but they don't have to. There are Medicare Advantage plans that are available that do not have drug coverage, so it's very important that an individual who wants to get their drug coverage through their Medicare Advantage plan is paying attention to that whenever they enroll. There's 2 primary ways that people receive their Medicare benefits. The first way that we're going to look at over here on the left side where it says Original Medicare, some people just choose to utilize their original Part A and Part B of Medicare. They may decide to add a Part D prescription drug plan, which we hope they do because prescriptions are incredibly expensive. And then they also may choose to enroll in a Medicare supplement plan. Medicare supplement plans are also known as Medigap plans, and as the name says, it's there to cover the gaps that are left over after Original Medicare pays what they're going to pay on those medical claims. The other option is on the right of the screen where it says Medicare Advantage plans. These again are the HMOs and the PPOs that are out there, and these are plans that cover all of the Part A and Part B covered Medicare services. They may also include drug coverage, and then they'll usually throw in a little bit of something extra, maybe a little dental coverage or hearing coverage or something like that, just to encourage people to enroll in their plan. Now, one of the primary, from the perspective of the beneficiary, one of the differences between these two options is if a person goes to the physician and that physician generates a claim. In the model on the left, the original Medicare model, the first place that claim is going to go is to Medicare for them to pay their part of the claim. As you know, let's say it's a Part B claim, Medicare Part B is going to pay roughly 80% of those costs. Then after Medicare has paid their part of it, if that person has a Medicare supplement plan, the claim is then electronically generated to that Medicare supplement plan to cover what part of the claim they're going to cover. If the person goes the route of the Medicare Advantage plan, however, the claim goes directly to the Medicare Advantage plan. Medicare never sees that claim. The Medicare's not even aware they went to the doctor. That's because Medicare has contracted with that Medicare Advantage plan to provide all those Part A and B covered services. They are already paying that Medicare Advantage plan a monthly fee that's based on the client's age, sex, where they live, et cetera, et cetera. They're paying that money to that plan every month to manage the health care for that client. So that's kind of the primary differences from the perspective of the beneficiary. Now, for people who are already receiving their Social Security benefits, they're all, maybe they retired at age 62, those people are going to automatically get enrolled in Medicare. They will receive a packet approximately 3 months prior to their month of eligibility that contains their Medicare card and other information that they may need. Now, for people who retire from the railroad system, they don't go through Social Security. Theirs is handled through the Railroad Retirement Board. So it's a little bit different. If you're dealing with someone who's a railroad retiree, they don't go to Social Security for this stuff. They use the Railroad Retirement Board. The way you can tell the difference between someone who is enrolled in Medicare through Social Security versus someone who is enrolled through the Railroad Retirement Board is, on the Medicare number, how there's a letter at the very end of the number. Well, with a railroad retiree person, the letter appears at the front of the number. So if you see the Medicare card looks exactly the same. There's absolutely nothing on the card that will look any different. The only way you will have of identifying that person is by the fact that that letter appears at the beginning of the name rather than the end of the name. The number, excuse me. Now, for people who are enrolled in Medicare due to disability, those people, as I said before, they've been on disability for 24 months. They qualify for Medicare in their 25th month. And again, they'll receive a packet approximately 3 months prior to their Medicare taking effect. Now, if a person is automatically enrolled in Medicare, it's going to come to them and it'll have them enrolled in Parts A and Part B. As I said before, most people get their Part A premium free. However, everyone pays for their Part B. It's $104.90 in 2014. And by the way, that is going to stay the same for 2015, $104.90. Now, a person does not have to take out Part B. They have the right to refuse Part B. If they choose to do so, what they need to do is they need to take that card that they've received in the mail, and on the back, you'll see right over here, there's a box that they can check that says, I don't want to take out my Part B. They can check that box, sign the card on the back, mail it back to Social Security. Social Security will generate a new card for them that only has Part A on there. And we're going to talk in a minute about why someone might not want to take out their Part B yet. If a person isn't automatically enrolled in Medicare, then they need to call Social Security to get enrolled. They need to do that, roughly 3 months. There's an enrollment period that we're going to talk about in a second. That's the best time for them to get enrolled. Now, again, if they're a railroad retiree, they need to call the Railroad Retirement Board to get enrolled. A person does not have to be retired to go ahead and take out their Medicare. Folks are working way past the age of 65 nowadays, so it's worthwhile for them. If they're already going to get their Medicare Part A premium free, they should certainly go ahead and take advantage of that and get their Medicare started when they turn 65. Now, this is an example of the initial enrollment period. This is the time period for everybody who first becomes eligible for Medicare. And as you can see on here, it's the 3 months prior to the month you're eligible, the month you become eligible for Medicare, and the 3 months following. If a person gets enrolled in one of the 3 months prior to their month of eligibility, their Medicare benefits are going to kick in the first of the month in which they turn 65. Doesn't matter if their birthday is on the 15th or the 21st or whatever, it will be the first of the month. If they wait to get enrolled in Medicare until the month they turn 65, it will not become effective until the first of the following month. If they wait to that first month after their month of eligibility, it will be the first of the following month. So you see how it kind of lags behind by 1 month each time. If a person does not take advantage of getting enrolled during their initial enrollment period, their next opportunity to get enrolled in Part B won't occur until the general enrollment period, which is January 1st through March 31st of each year. And the coverage will not begin until July 1st. And this is very important. If a person does not take out their Medicare Part B when they are first eligible, and they have to wait till that next general enrollment period, they're going to pay a late enrollment penalty. That penalty is 10% of the monthly Medicare Part B premium for every 12-month period they were eligible but not enrolled. And that 10% gets tacked on to their monthly Part B premium, and they will pay that from now on. It's not just a one-time penalty. So it's very important that people take advantage of that and get enrolled when they're supposed to. Now, there are some times when a person can delay taking out their Part B and they don't have to worry about the penalty. Specifically, that's going to be when a person has coverage through active employment through an employer. In other words, they've got group health insurance through an employer. It could be they're still employed, or if not them, they may be retired, but their spouse is still employed and has them covered under their health care coverage through their employment. Those people can actually delay taking out their Part B until they no longer have that additional coverage. So that saves them that $104.90 because they've got coverage through active employment. Now keep in mind, it's active employment. That's not COBRA. That's not a retiree plan through the employer. It has to be active employment. And it's always a good idea to check with the employer or the union benefits administrator to see how that coverage works with Medicare. Now, when that employment coverage ends, a person has up to 8 months to get signed up for Medicare without having to worry about paying that penalty. Now, we hope they don't wait 8 months because that's 8 months they're going without any insurance. So we're really hoping that they will take advantage and get signed up as soon as possible. One of the advantages for a person to delay taking out their Part B until they no longer have that group health coverage is because it delays the beginning of their Medigap open enrollment period. And I'm going to talk more about this later, but the important thing about that is when a person first turns 65 and they enroll in their Part B, as in boy, that starts a 6-month period in which they can purchase a Medigap policy. They cannot be denied because of any pre-existing health conditions, nor can they be charged more because of any pre-existing health conditions. We'll touch on that more in a minute. Now let's talk very quickly about Part A and Part B and what exactly those two parts cover. We're going to start out with Part A. As you know, it covers inpatient hospital services. It also covers skilled nursing facility, home health care, hospice care, as well as blood products. Now, paying for Part A, most people get their Part A they get it premium free because, as I said before, they've worked 10 years and they've been paying FICA taxes into the system. If a person has worked less than 10 years, they can get Part A, but they're going to have to pay for it. If a person has worked between 30 and 39 quarters, then they can get their Medicare Part A for half of that premium. So it'd be a little over $200 a month they would have to pay for their Part A. If a person has worked less than 30 quarters, however, then they would have to pay the full amount, which for 2015, as I said, is $407. It's going to cover inpatient hospital care. That includes a semi-private room, meals, general nursing, all of those usual things that a person has when they go into the hospital for inpatient treatment. Now, what's different about Medicare Part A is Medicare Part A, most of our insurance products, we're used to hearing the term annual deductible, annual this and annual that. With Part A of Medicare, it's very different. It's based on benefit periods. A person begins a benefit period the day they go into the hospital. And that particular benefit period does not end until that person has been out of that facility for 60 consecutive days. So it doesn't matter how long they were in the facility. If they were in there 5 days, 20 days, 40 days, doesn't matter. What ends the benefit period is the fact that they have been out of that facility for 60 consecutive days. And that's important because that establishes what's going to come out of that beneficiary's pocket versus what Medicare is going to pay for. So the first thing that's going to get paid when a person goes into the facility is going to be the deductible, which for 2015 is $1,260. That is the new number for 2015. There is no limit to the number of benefit periods you can have in a calendar year. So here's a graph that shows for days 1 through 60 per benefit period, the individual would pay $1,260 deductible, and that covers them for the first 60 days for that specific benefit period. For days 61 through 90, they pay $315 per day. For days 91 through 150, $630 per day. Now, to stick with what we were talking about with benefit periods, let's say that we have a patient that was in the hospital for 45 days, and then they were discharged from the hospital, but they came back into the hospital. It doesn't even have to be for the same diagnosis. It can be for any reason. But they come back into the hospital within, say, 15 days. They would still be within that same benefit period. So they would not pay that $1,260 deductible again. They would simply pick up at day 45, or day 46 of that specific benefit period. They would have from day 45 through 60, and then they would start paying that per day charge that's associated with day 61 through 90. If that same individual had been in the hospital for 45 days, left the hospital and came back to the hospital in 90 days, they would in fact have to pay the deductible again. So I know that's a little bit confusing, but I want to make sure people understand that. The other thing that I want to make sure that people understand is that for days 91 through 150, these are considered lifetime reserve days. Days 1 through 90 of each benefit period renew. Every time you have a brand new benefit period, you get a whole brand new days 1 through 90. However, days 91 through 150 do not renew. Those are lifetime reserve days. And once you start eating into those days, those will not come back. So it's important that folks understand that. Now, thankfully, nowadays with modern medicine, we don't have people who are staying in the hospital for those lengths of stay anymore. Skilled nursing facility care is also covered by Part A. It's required, this is a facility, most of you already know this, but it's a facility where a person can go to continue recovering. They're not receiving the same level of care that they previously received in the inpatient hospital setting, but this person still cannot go home. They either can't bear weight or they need medications. They need the services of some skilled professional to continue their treatment. To qualify for skilled nursing care, they also have to have been in the hospital for 3 consecutive days. And this is an important distinction because observation days do not count toward meeting the nursing facility criteria. So it's very important that beneficiaries are aware of the fact whether they have actually been admitted, fully admitted to the hospital, or if they have been admitted under observation. Because we have a lot of people that think that they're going to qualify for skilled nursing facility and they don't because they may have been in the hospital 5 days, but 3 days of that with observation. Now, they don't have to go directly to the skilled nursing facility. They may have gone home first and they couldn't make it, but as long as it's within the generally 30 days from leaving the hospital, they still qualify for skilled nursing facility care. And they do have to be going to the skilled nursing facility for the condition for which they were admitted to the hospital. They can't have been in the skilled nursing, they can't have been in the hospital and gone home and gotten pneumonia. It has to have been either the condition that they were treated for in the hospital, or in some cases they may have contracted a condition while they were in the hospital, such as an infection. Under those circumstances, they would also qualify for skilled nursing facility care. These are the things that would be qualified in skilled nursing facility care, sometimes the question comes up about what medical social services means. That's where someone is basically coming in and while the person's in the skilled nursing facility, they're evaluating them for what's going to come up next. You know, if they're going to go home, is the home environment set up for them to successfully transition back into the home setting? Do they have wide enough doorways? Do they have any stairs to worry about? Do they have a support system? That sort of thing. Paying for skilled nursing facility care per benefit period, again, because we're still talking about Part A. Days 1 through 20, they don't pay anything. For days 21 through 100 during that benefit period, they would pay $157.50 in 2015. After days 100, they would pay all the costs. Home health care. Home health care is, again, they need some skilled level of care that can successfully be provided in the home setting. The person has to be homebound. Homebound does not mean that they absolutely physically cannot leave the house. Homebound simply means that it's difficult. They've actually gone in recently and they've sort of updated the definition so it's much more clear. If you wanted to go online, you could basically Google Social Security Act Section 1835A and it would tell you what the criteria is. Basically, a person it's fine for them to leave the house for short periods of time, such as if they had to go to a doctor's appointment, if they had to go to the beauty shop. They would even be able to attend something like a family reunion. It just simply means that it's difficult for them to leave home. They need assistance to leave the house, whether that's by equipment or by a person that's assisting them, and they can only be gone for a short period. They do have to be under the care of a physician, and there has to be a treatment plan, and they do have to have a face-to-face encounter with the physician prior to the start of that care. Frequently, if that's a situation where a person is going from the hospital to the home setting, that face-to-face doctor encounter could actually be the hospitalist right there at that hospital. And the home health agency does have to be a Medicare-approved provider. Next, home health care. Home health care is, well, we're still on home health care. Sorry about that. It's fully covered by Medicare. They don't have to pay anything. The plan of care has to be reviewed every 60 days. That's called the episode of care. And they're reviewing to make sure this person still meets the criteria and still needs the home health care, that level of care. In original Medicare, they're not going to pay anything for the home health care services, but let's say that they have to have some piece of equipment that home health agency is helping them work with. Maybe it's a walker or a wheelchair or a tub transfer bench, something of that nature that would be covered under the durable medical equipment coverage that's provided by Part B. Therefore, the person would pay roughly 20% of the cost of that piece of equipment. Hospice care is for people who are expected to live less than 6 months. They've chosen not to go the route of treating their condition. It's going to focus on pain relief. They're no longer trying to cure whatever this condition may be. The episodes of care, they're arranged into benefit periods. The first 2 benefit periods are 90 days long. And as we said earlier, this person is expected to live 6 months or less. Therefore, those 2 90-day benefit periods would take them to the end of that 6-month expectation. If, however, that person is still with us, and frequently nowadays in hospice care, people are living way past 6 months, then they have an unlimited number of 60-day benefit periods. However, every 60 days, that person has to have a face-to-face encounter with a physician, nurse practitioner, or a physician's assistant who is either employed by or contracted directly with that hospice company. It does have to be a Medicare-approved hospice provider. These are the things that are going to be covered by hospice care, and it's a full range of services there. It also includes respite care. Respite care is, sometimes the person who's the primary caregiver for this individual needs a break. Maybe they've got some business they need to take care of, or they just need to recharge their own batteries. They can qualify to go into respite care up to 5 days each time. There's no limit to the number of times that they can access respite care. So that can be a really great service for those folks. As far as paying for hospice services goes, in original Medicare, they don't pay anything for hospice care, and they pay up to $5 per prescription that is utilized for the management of pain and symptom control. Okay? Now, these people may have other medication needs, so they may still need to have a Part D prescription drug plan to cover those other prescriptions. If they go into respite care, they're basically going to pay 5% of the cost for that inpatient respite care. If the person is on Medicaid and living in a nursing home, hospice is not going to pay for the nursing home charges. That's considered the person's residence. That's where they live. That would continue to be being paid by Medicaid. Blood is also covered by Part A. A lot of facilities get their blood for no cost. They don't pay anything for those blood products. And so if they don't pay for the blood products, neither does the patient. However, if the hospital has to pay for those blood products, the individual is responsible for the first 3 units per calendar year, or unless someone has donated blood to replace in the blood supply. That was Part A, and we're going to move right into Part B because our time is getting away from us. Part B covers outpatient services. Doctor services, whether that's primary care or specialist services, are covered by Part B. Outpatient services like surgeries, laboratory, x-rays, MRIs, things like that would also be a Part B service. Durable medical equipment is also covered by Part B of Medicare. And for some of you, you may live or work primarily in what's called a competitive bid area. A few years ago, Medicare decided to update their system and come up with a way to try to save some money for a couple of reasons. One, the Medicare system was not actually paying accurate prices for a lot of the equipment that they were providing, and Medicare actually was paying too much. There was pieces of equipment that they were covering that the cost that Medicare provided for those pieces of equipment was extensively higher than what a person could go to Walgreens and just pay for it off the shelf. So it updated their system in terms of what they were paying. The second thing that it did, though, is it stopped a lot of the fraud that was taking place in the DME system. Durable medical equipment was fraught with all kinds of fraud. It was probably the easiest area in which a person could commit Medicare fraud. So now if a person who lives in a it's called a DMEPOS competitive bid process. DMEPOS is durable medical equipment, prosthetics, orthotics, and supplies. If a person lives in a competitive bid area, they have to utilize the Medicare contracted provider to get that piece of durable medical equipment. If they go to a provider who is not contracted with Medicare specifically for that piece of equipment, the provider is responsible for informing them that they are not contracted to provide that piece of medical equipment and to direct them to a contracted Medicare provider. Home health care services, if a person does not have Medicare Part A, then Medicare Part B can pay for those home health services. It would fall under the Part B part of it. Also, other services that might be, kidney dialysis services falls under Part B. A lot of the outpatient mental health stuff falls under this, EKGs, transplants, etc. A lot of that stuff is going to fall under the Part B of Medicare. Also, preventive services. Not so long ago, Medicare did not cover preventive services. They only paid whenever you got sick. So now, however, Medicare Part B is now covering a lot of these preventive services. Some of them are covered at 100%. Some of them are not, however. Some of the things that are covered at 100% is going to be like the annual wellness visit or the Welcome to Medicare visit. Bone mass measurement is covered at 100%. Colonoscopy, mammography, those are all 100%. However, there are a range of them, such as prostate cancer screening. That is not covered at 100%. So it's, you can get a list of those. You can just look online and find out which are covered at 100% and which are not. Things that are not covered by Part A and Part B, long-term care, which is nursing home care, routine dental care, dentures, cosmetic surgery, et cetera, those things are not covered by Medicare. Paying for Part B, most people are going to have a deductible of $147. That was the deductible for 2014. It's going to remain the same for 2015. And then after they've paid that deductible, they'll pay roughly 20% of the cost for most of the services that they receive. There are some assistance programs that we're going to talk about later on that can help pay for some of those costs. Now, some people who make a lot more money than most seniors will actually pay more for their Part B premium, and it's based on your tax return from the prior 2 years. If an individual is making $85,000 or less, filing their taxes individually, or if they file jointly and they make $170,000 or less, they are simply going to pay their $104.90 monthly premium for their Medicare Part B in 2015. If, however, they make more than that, and you can see on the chart here for yourself which categories these folks would fall into, it tells you how much they would pay for their Part B in 2015. Keep in mind this impacts less than 5% of all Medicare beneficiaries, so you don't often run into someone who is actually paying this amount of money. Now, As far as paying for the Part B premium, most people get it deducted from their either Social Security benefit payment or railroad retirement payment. Feds, people who retire from the feds can actually get it deducted from their retirement payment as well. For those people who choose not to have it deducted from those benefit payments, they can actually set up an account, it's Medicare Easy Pay, that gets deducted from their bank account every 3 months. And so you can contact any of those agencies listed at the bottom to find out how that gets done. As I said before, if a person delays taking out their Part B and they do not have creditable coverage through active employment, they will have that 10% penalty for every 12-month period they were eligible and did not sign up. And they will pay that penalty for as long as they've got their Part B. So we really try to get people signed up as early as possible. Now on Part B late enrollment penalty, this is just kind of a quick example that shows us this individual delayed taking out her Part B for 2 full years, and so consequently, the Part B premium being $104.90, she's going to have $20.98 that's going to be tacked onto hers because of the 2 years that she delayed taking that out. So this individual will actually be paying $125.90 a month for her Part B. Keep in mind, if next year the Part B premium goes up, let's say it goes up to $106, she will then start paying 10% or rather 20% of that amount because it's based on the current year's Part B premium. Now, I wanted to also point out while we're in this section talking about Part B, because the question always comes up, does the fact that the person has Indian Health Services coverage count as creditable coverage to delay taking out Part B? It does not. If a person has access to Indian Health Services funds to pay for their health care, they can use that. They can make that choice. But if they later on decide they want to take out Medicare Part B, they will pay that penalty. The same is true for people who have Veterans Administration VA benefits. Now, the different coverage choices. Let's move on into this. Original Medicare, you pretty much know. We've already talked about what these things are and how they work. With a person that's on a Medicare Parts A and Part B, they're basically going to get a Medicare summary notice that gets sent to them on a quarterly basis that tells them what claims Medicare has paid on their behalf. And we hope these people are taking advantage of getting enrolled in a Part D drug plan to cover their prescriptions, because in most situations, Medicare is not going to cover any outpatient prescriptions this person may take. Assignment, you know, you hear people use the term that the provider accepts assignment. That basically means that this doctor has entered a contract with Medicare, and he's agreeing to file claims directly into the Medicare system, and he's agreeing to accept the Medicare fee schedule as payment in full for the services that he provides. So most of the time we tell people, try and make sure that you're seeing providers who accept assignment. If a provider does not accept assignment, maybe he still sees Medicare beneficiaries, but he does not agree to accept assignment, they can do that, but the most they can charge a Medicare beneficiary is 15% more than the Medicare approved fee schedule. And a lot of people don't know that. So it's important that they understand if that doctor doesn't accept assignment, he still should only be charging at the most 15% more than that fee schedule. There are some times when doctors have to accept assignment, and that would be in the case of any Part B covered Medicare prescription drugs. That would include some of the chemo drugs that are taken orally, and then also ambulance suppliers are also required to accept assignment. Private contracts, we don't run into this hardly at all in Oklahoma because we just don't have people that have the financial wherewithal that they could afford to do something like this. But if a beneficiary enters into a private contract with a doctor, Medicare is not going to pay a dime. There are some doctors out there who do not accept Medicare, they don't accept any insurance, and they require their patients to sign a contract saying that they agree to pay him on a fee-for-service basis. Anytime a beneficiary does that, Medicare isn't going to pay anything, nor is Medicaid. It's a private contract. They shouldn't submit their claims to Medicare because Medicare will not honor that. Also, any provider that enters into such a private agreement is not eligible to receive any Medicare payments for any of their patients for up to 2 years. Medigap coverage is private insurance. It's offered through private companies you've heard of before, like Mutual of Omaha, Bankers Life, Humana, all of these companies, and they're sold by these private companies. It's regulated on the state level, whereas most of the regulation with the other parts of Medicare takes place at the federal level. And the single best time for somebody to purchase a Medigap policy is during this open enrollment period that, as I said earlier, begins when a person signs up for their Part B. Once that starts, once a person has enrolled in Part B, the clock starts and it can't be delayed nor repeated. So that's one of the reasons why we encourage people not to enroll in Part B if they have group health coverage that's considered creditable by Medicare. With a Medigap policy, you are going to have a monthly premium. Sometimes that monthly premium is higher than what a premium would be for, say, a Medicare Advantage plan that we're going to talk about in a moment, but they're very flexible. A Medigap policy is good anywhere in the country that Medicare is accepted. So if a provider accepts Medicare, they will accept your Medigap policy. The cost will vary by the plan and by the company that offers those plans. The Medigap policies are actually standardized. That means there are set benefits assigned to each one of these standardized policies, and we're going to see a graphic here in a minute that illustrates that. And these states sell these policies as standardized with the exception of 3 states, Massachusetts, Minnesota, and Wisconsin. They standardize their plans a little bit differently, but everywhere else in the country they do it this way. It's also important for people to understand Medicare supplement plans do not work with Medicare Advantage plans. There is no benefit whatsoever to a beneficiary having both a Medigap policy and a Medicare Advantage plan. They don't coordinate. They don't work together. The one plan will not pay the difference of what's left over after the other plan is paid. Now, this is the graphic I was talking about, and you see along the top of the graph here those letters. Those letters represent the 10 standardized plans, and running down the left side of the page, you'll see the benefits. And so with a beneficiary who's looking to buy a Medigap policy, they need to identify which of those benefits they want to make sure is covered. Now, keep in mind, Medicare is going to pay what Medicare pays regardless of whether you've got a Medigap policy or not. They will pay, for instance, for Part B services, they're going to pay roughly their 80% after you've met the deductible. So this is a Medicare supplement. It's simply supplementing what Medicare has already paid. So you look down through here and you find which benefits it is that the client is interested in having covered so they don't have to worry about paying it. And then based on that, they've identified which of the standardized plans that they're looking for. Now, as I said earlier, the benefits are standardized. It does not matter what company you buy it from. Mutual of Omaha, Bankers Life, any of those companies, the benefits for a Plan A are going to be the same regardless of who you purchase it from. What will be different is how much you pay for it, and the amount that they charge is significantly different. In Oklahoma, we've got a Medicare Supplement Shopper's Guide that we publish every year that has estimates in it of what those premiums would be with those different companies, and the cost for those plans can vary tremendously, and we just try to stress to beneficiaries you're not going to get any additional benefits by paying more money because those plans are standardized. Now, Medicare Advantage plans. This is Part C of Medicare. These are the HMOs and the PPOs that are out there they're run by private insurance companies. They're heavily regulated by the feds. With these plans, Medicare Advantage plans are required to cover all the Part A and Part B services that a person on original Medicare would get from their Part A and Part B. Medicare is already paying a certain amount each month to that plan to take care of that beneficiary's medical needs. And frequently the beneficiary will also have a premium that they have to pay as well. And in exchange for having this Medicare Advantage plan, there are certain rules that each beneficiary that's enrolled with that plan has to agree to follow. And each of those plans vary significantly. We'll talk a little bit about what each of those are. People who are on Medicare Advantage plans, they don't lose their Medicare. They're just using a different mechanism to get their care provided to them. They have all the same rights and protections. They get all the same Part A and Part B covered services. And a lot of times the Medicare Advantage plan also includes their drug coverage. So a lot of times we stress to those individuals that they want to make sure that the prescription drugs that they take are on the formulary for that Medicare Advantage plan. And a lot of times the Medicare Advantage plan will throw in some extra services. There may be a little vision coverage or dental coverage. It's not going to be a full-blown dental policy. It's just going to be maybe a couple of teeth cleanings or something like that, or maybe some x-rays or something. And the benefits of the cost sharing are going to differ depending on the type of plan that it is. There's different kinds of plans that are available out there, and we'll talk about a few of those very quickly. The health maintenance organizations, those are the ones that are probably going to be the cheapest, but they're the most restrictive. With an HMO, you're going to have a contracted network of providers that's going to include your physicians, hospitals, therapists, everybody. And you're required to utilize the contracted network to provide all your services. If you go outside of that network, then you could be held 100% responsible for those medical costs. Now, in the case of an emergency, that would not be the case. Any time a person's in an emergency, they can go to the nearest emergency room and they will be treated. However, if a person is outside of the service area and they just get sick, they're running a little fever, or they're throwing up or something like that, something that would not be considered an emergency, they would be expected to come back in network to receive care. The next one I wanted to touch base on is the third one down, the preferred provider organization. It's a lot like an HMO because it does have a contracted network, but it also has an out-of-network benefit where a person, if they want to see an out-of-network provider, they can choose to go to an out-of-network provider, but they're going to pay more money. Typically, when they start using their out-of-network benefits, they'll have a deductible, and then the plan will pay a percentage of what their medical costs were. There are special needs plans that are this is a Medicare Advantage product that is for a specific group. It could be based on a certain diagnosis. It could be based on where a person lives. There are also special needs plans that are specifically for people who are dual eligible. All right? And it's just a Medicare Advantage plan that's specifically for those folks. Private fee-for-service plans are a little bit different than the others in that on a private fee-for-service plan, you can see any provider that you want to, provided that that provider is willing to accept your insurance. You have to go to the provider each time you seek care and say, this is my insurance, will you agree to accept it? And the individual can either accept that insurance or not. And just because they took it the last time does not mean they have to agree to accept it again. So it's very important that beneficiaries understand that anytime they seek care, they need to make sure that that provider is going to accept it. That would include a situation where a person has gone into a hospital. And, when you go to the hospital nowadays, you don't just have one bill from the hospital. You've got pathology bills, radiology bills, et cetera. They need to make sure that all the parties that are involved are going to agree to accept that. The cost for Medicare Advantage plans, people still have to pay their Part B premium. The same would be true with Medicare Supplement plans, by the way. If a person wants a Medicare Supplement plan, they do have to take out Medicare Part A and Part B, and the same is true with Medicare Advantage plans. You have to have A, and you also have to pay your Part B premium. Depending on where you live, you might have some Medicare Advantage plans that don't have a monthly premium that they charge to beneficiaries. But by and large, particularly in states that are more rural, such as Oklahoma, more of our plans, they actually have a monthly premium that they also have to pay. There are just like with original Medicare, there's some deductibles and coinsurance and copayments, but they're going to differ from the way original Medicare runs. As you know, with Medicare Part B, you pay a deductible, and then you pay roughly 20% of the cost for your care. With a Medicare Advantage plan, probably what you would see is if when you go to a physician, rather than having a deductible and a percentage coinsurance, you'll have a copay. $10, $15, $20, whatever the copay is for that particular plan, and it does vary from plan to plan. And if you go out of network, you're definitely going to pay more money. There are certain rules for being in a Medicare Advantage plan, such as you do have to live within the plan service area, you do have to have Medicare Part A and B, you cannot have been diagnosed end-stage renal disease. If you've been diagnosed end-stage renal disease, you no longer qualify for a Medicare Advantage plan. Now, if you were already enrolled in the Medicare Advantage plan and then were subsequently diagnosed end-stage renal disease, you can stay with the Medicare Advantage plan. You don't get kicked out. You do have to provide the necessary information in terms of for enrollment to get enrolled in that particular plan, and you can only belong in one plan at a time. The best time to get enrolled in Medicare Advantage plans, you've got the same initial enrollment period that we saw for people who are enrolling in their Part A and Part B. We're currently in the open enrollment period for Medicare Advantage plans that runs October 15th through December 7th of every year. This is the single best time of year for a Medicare beneficiary to make some changes that could save them money for the coming year. And any changes they make during this time period will become effective January 1st. And the plans do have to allow new members to join. With Medicare Advantage plans, they cannot deny you coverage based on a pre-existing condition. other than end-stage renal disease, unfortunately. Now, with the special enrollment periods, there are certain times when a person outside of the aforementioned enrollment periods can change their enrollment. Let's say that they move out of the planned service area. If an individual was to move from Oklahoma, say, to Dallas, Texas, they would be outside of their current planned service area. They would have a special enrollment period to disenroll from the plan they were currently in and enroll in a product that was available down there in Dallas, or to go back to a traditional Medicare and pick up a Part D drug plan if they chose. Also, if their Medicare plan leaves this market, there's been a lot of plans that pulled out of the service areas in some states across the country. If that plan leaves the service area, those individuals have a special enrollment period to pick up something else. Also, if they enter in, leave, or are living in a long-term care facility, they have a special enrollment period. So you can see the other things down there that would impact that. Let's go ahead and move on to another slide. Now, there is a 5-star rating system that Medicare has employed with Medicare Advantage plans, and any plan, as I said before, October 15th through December 7th is the open enrollment period. That is the only time that most of these plans have to get new members enrolled in their plans. However, if they manage to achieve a 5-star rating on their plan, and that's 5 stars across the board, not just in one section, then that plan can actually enroll people throughout the year. So it's kind of a big benefit for them. And so a lot of companies are really striving to get that 5-star rating system, which is a benefit because that increases the quality of care for Medicare beneficiaries. There's also a disenrollment period that runs January 1st to February 14th. That's for people who got enrolled in a Medicare Advantage plan, but then later on changed their mind. They decided that wasn't really for them. So those people have the right from January 1st to February 14th to disenroll from the Medicare Advantage plan, go back to traditional Medicare, and pick up a Part D drug plan. There are other types of Medicare plans. They're not available everywhere. Medicare cost plans it's a Medicare Advantage product, but it has an out-of-network benefit where if a person is enrolled in that plan and they choose to go outside of the Medicare Advantage network, their Medicare benefits kick in, and it basically just pays as a Medicare plan. There's always some kind of demonstration project or pilot project that's going on out there, and people can enroll in those, but they need to understand they are time limited. They won't go on forever. The last one that's listed there is programs for all-inclusive care for the elderly, or PACE programs. These are programs that are Medicare Advantage products that are available to seniors who meet the criteria they meet nursing home criteria. So it not only provides all of the medical care costs and stuff, but also some social services as well. And there's programs like this cropping up all over the place. Now, quickly, we're going to cover Part D because we're running out of time. Part D is the prescription drug coverage. It's run by private insurance companies. It's available to everyone who has Medicare. You do have to actually enroll in a plan. It's not going to happen automatically. Some people get their prescription drug coverage from a standalone prescription drug plan. Other people, as we said earlier, choose to get their drug coverage through their Medicare Advantage plan. The costs are going to vary significantly. There's 30 plans in Oklahoma. There's 30 plans that are going to be available for next year, and I know we by far don't have the most. Last year we had 34, so that number is reduced. People who have a drug plan, a lot of plans have a monthly premium, or all of them will have a monthly premium. Some of them have a yearly deductible. The maximum deductible allowed for 2015 has gone up to $320. Now, there are some plans out there that have no deductible, and for some people that's an important feature. They'll have certain copays and coinsurance that they pay for their medications. Also, for people who go into the coverage gap, and we don't have a lot of time to talk about the coverage gap, but I've got a slide on it here in a minute. People who go into the coverage gap are going to pay 45% of the costs of any brand name drugs that they take, and they will pay 65% of the cost for any generic drugs that they take. And then after they reach the out-of-pocket max of $4,700, they'll pay very, very little. They'll pay roughly 5% of their drug costs. Now, this is one example of how the donut hole works, but in the interest of time, I'm going to show you this one because I think it illustrates it a little bit more easy for people to understand. And I'm going to try really hard to use these arrows effectively, and if I mess up, forgive me. When a person starts the beginning of the year, this particular individual, and also, by the way, I need to point out to you that this is based on 2014 information. I don't have the updated slide yet. My graphic artist is just a little bit behind. So this is basically talking about for 2014. So this individual was enrolled in a plan that had a deductible of $310. That individual will pay the first $310 of their prescription drug costs for this year. After they've paid that $310, their plan will actually kick in and start paying roughly 75% of their drug costs, and the individual will pay the other 25%. Once the combined total of what the enrollee has paid and the plan has paid, along with the deductible, totals this $2,850, that person goes into what's called the coverage gap. When the person is in the coverage gap, then it's going to be a combination of what they pay, what the plan pays, and then also a discount they receive from the drug manufacturer. So over here on this side of the screen, you're going to see the brand name side. During the time period that a person is in the coverage gap, they're going to get a 50% discount on those brand name medications, and that 50% is actually paid by the drug manufacturer. The beneficiary is going to pay 45%, or last year they paid 47.5%. In 2015, they'll pay 45% of those brand name costs. Down here in this little bitty part you see right there, there's a 2.5% charge that's actually paid by the health plan, okay, in 2014 for administration costs. In 2015, that's going to go up to 5%. Now, over here on this side, you see the generics. The beneficiary paid 72% for their generic drugs in 2014. They'll pay 65% of the cost of their generics in 2015. The remainder would be paid by the health plan. Now, the reason why this is kind of color-coded on this chart is I need to point out to you that once a person goes into the coverage gap, anything that was paid by the plan here, here, and here does not apply to getting them out of the donut hole. It does not apply to this thing over here that's called the TROOP, the true out-of-pocket costs. Okay, the only things that will apply to that is the cost, anything that has been paid by the beneficiary, anything that was paid by the manufacturer toward that discount, and there are some other funds that would apply toward this as well. That would include anything that is paid by Indian Health Services. If Indian Health Services helps pay for anything during this time period, that would also apply to covering this troop. Okay? Once the combined total of what has been paid by the individual, Indian Health Services perhaps, the drug manufacturer, once it reaches this number over here of $4,550, that person comes out of the coverage gap. During that time period, once they reach that level, the enrollee pays roughly 5% of their drug costs for the remainder of the year. Now, it sounds like a lot of money, but I help a lot of people who go into the donut hole as early as March because their drugs are so expensive. And so for the majority of the year, they actually find themselves up here in what is called the catastrophic phase, where they're only paying that 5%. Now, that was a lot of information to go over very quickly, and I'm happy to go over it again with somebody if they need me to do it at a slower pace at a different time. This is a graph that kind of shows you I'm trying to get that to go away. There we go. That shows you the discounts. They started a few years ago, probably 4 or 5 years ago. There was no discounts in the coverage gap. When a person went into the coverage gap, they had to pay 100% of their drug costs. But then starting back in 2012, 2013, they started applying discounts, trying to slowly close the coverage gap over time. Beginning this coming year, a person will pay 45% of their brand name drug costs and 65% of their generic drugs. And you can see how each year those discounts increase until by the year 2020, a person is going to be paying roughly 25% of their costs for both generics and brand name drugs while they're in the donut hole, which in effect will close the donut hole because, as you saw in that previous graph, when the insurance company is paying for their drugs, they're paying roughly 25% at that time anyway. Some people will also, we saw in Part B where some people will pay additional money because they make more money, and we use the same criteria for those folks. If, again, this only impacts roughly 5% of all Medicare beneficiaries, so we'll go ahead and keep moving. To be eligible to join a Part D prescription drug plan, a person has to have A or B. You'll remember a moment ago I said to have a Medicare Advantage plan or a Med Sup plan, you had to have both. With a prescription drug plan, you just have to have one or the other. You do have to live in the plan service area, but a lot of the Part D plans have now gone nationwide, so their service areas are much, much larger than the service areas for Medicare Advantage plans. And you do have to actually enroll in the drug plan. It's not something you're automatically going to be enrolled in unless you qualify for certain special assistance programs. The best time to start it is, again, during that same 7-month initial enrollment period. However, they also can make changes each year to make sure that they're on the best possible plan for the coming year from October 15th through December 7th. The disenrollment period does not apply to standalone prescription drug plans. It only applies to people who are on Medicare Advantage plans. But again, if they're on a Medicare Advantage plan that provides their drug coverage, they could disenroll, go back to traditional Medicare, and pick up a Part D drug plan. Then again, they have pretty much the same special enrollment periods that people with Medicare Advantage plans have. There is a late enrollment penalty associated with Part D prescription drug coverage. If a person delays taking out a Part D plan and they don't have other creditable coverage, they will pay 1% of the base beneficiary premium, and that's a number that's established each year by the feds. For the coming year, that number is actually going to be $33.13. So they would pay 1% of that amount for every month they were eligible for Part D and did not take it out. Now, previously we talked about how Indian Health Services coverage did not count as creditable coverage for Part B. However, for the purposes of Part D prescription drug coverage, IHS coverage as well as VA coverage both count as creditable coverage. So a person could, in effect, delay taking out Part D, and then in later years, if they decided they wanted to enroll in Part D, they could do so and not have to pay the penalty. Brand name drugs, it covers an array of drugs. It does also cover biologics, insulin, as well as the supplies for injecting insulin. The plan has to cover a range of drugs in each category. They can't just cover one blood pressure pill. They've got to cover several of them, and the coverage rules do change. They have to cover all of the drugs in these 6 categories that are listed here. They also have to cover all commercially available vaccines. That is with the exception of those that are the vaccines that are covered by Part B, which would include the flu shot and the pneumonia shot. But other vaccines, such as the shingles vaccine, must be covered by a Part D prescription drug plan. There are drugs that are excluded from Part D, which includes drugs for anorexia, weight loss, fertility drugs, et cetera, et cetera. They do have to cover a range of drugs in each category, as I said, and there's different ways that they manage people's access to those drugs. It's very important for people to understand that there is a formulary for each of the drug plans, and that's why we go do a thorough review of all the medications that the individual takes, because we want to make sure that all of the medications that they take are on the formulary for that particular drug plan. Otherwise, they're going to be paying full price for that drug because it's not on the plan's formulary. Then the plans will also use things like prior authorizations and step therapy to control access to drug to make sure that people are on the least expensive drug that will actually do the trick for their condition. Now, there are assistance programs out there, and very quickly I'll just make you aware, Extra Help is a program that helps people who are with their prescription drug costs. And if a person meets the criteria for Extra Help, then it will pay all or part of their Part D prescription drug plan, as well as reducing their copays. Now, for 2015, and it's not on our slide here, but I pulled it up offline, if a person's income is below $17,505 per year for a single person, or $23,595 for a married couple that are living together, and if their assets are below $13,440 for a single person and $26,860 for a married couple, they could qualify for Extra Help. Basically, the criteria for partial Extra Help is they're below 150% of the federal poverty level. For full Extra Help, they're at or below 135% of the federal poverty level. And to qualify for Extra Help, they can contact their local senior health insurance counseling program. They can contact Medicare directly if they want to. In Oklahoma, I know a lot of the people that work in the IHS system have gone through the training, and they're actually able to help people get enrolled in Extra Help, and it's a very useful program. It doesn't cost anything to get enrolled in Medicare in Extra Help, and they can apply as many times as they need to. So we encourage them at any point in time. Also, Extra Help does not include, if you're talking about assets, it doesn't include the house you're living in. It doesn't include the car that you're driving. So it's definitely worthwhile for someone to try to qualify. There are also Medicare savings programs out there that are available to folks. These help cover some of the Part A and B costs that are out there. The first one being the Qualified Medicare Beneficiary Program, And, these are for folks that they may make too much money to actually qualify for Medicaid, but they might still be low enough income that they qualify for one of these. With the Qualified Medicare Beneficiary Program, now these are 2014 numbers because I don't have the 2015 numbers yet, but in 2014, and until those change for 2015, the Qualified Medicare Beneficiary income amounts for 2014 were $993 a month for individuals, $1,331 a month for a married couple. And if a person meets the criteria for that plan, that's going to cover all their Part A and Part B premiums. It'll cover all the cost sharing like deductibles and coinsurance. Basically, it acts like a really good Med-Sup plan. The Specified Low-Income Medicare Beneficiary Program, they can make up to $1,187 as an individual or $1,593 as a married couple living together. That program would pay for all of their Part B monthly premiums. That's the $104.90. So that also can be very helpful to them. And the other programs are listed there, but I'm going to keep going to try to get through this so that we can have some questions. It's very important if people want to qualify for these, the best place to talk to is their local DHS office. Each state is a little bit different. In some states, my counterparts have the ability to help people enroll. We do not in Oklahoma. So I always refer people, talk to your local Medicaid agency, whether that's the DHS office or whomever, to try to get enrolled in those Medicare savings programs. Now, I'm going to stop there. We have a section here on rights and appeals, but in the interest of time, and I know you probably have questions that need to be answered, I'm going to stop, and if anyone needs to talk about the rights and appeals process, you can contact me privately, or we can come back and we can do another presentation, whatever you need to do. So I'm going to stop talking, and Chelsea, what would you like to do?
Hi, this is Kimberly. I just want to first of all thank you, Ray and Jolie, for all of the informative information you've just passed on. I think that it was, although it was a lot of information, I think that it was very helpful for our staff that are working at our urban programs and other tribal affiliated programs that have to work with patients and helping them understand the benefits and as well as some of the programming that will help them assess the cost of the premiums as well a little bit easier. So thank you so much for your time. And I also wanted to definitely open it up to questions. If there are any questions from any of the participants, feel free to write them into the Q&A pod or even in the chat pod. If you have any questions, we'll take some time to do that right now. I also want to mention that the slides as well as the recording link for this webinar will be provided to you in a follow-up message coming out later this week. So definitely look out for that email, and you'll be able to view the webinar again if you did not catch any all of the information at this time. I also wanted to mention that there is a, Jolie has provided a link in the chat box also for another organization that is able to help people in finding low-cost options, as well as if you just scroll through your chat box a little bit, it's right there, the pparx.org. They also provide help with prescription drug care for elders.
Hey Ray, this is Jolie. Since there's nobody chiming in with questions, I know you've been out doing a lot of community presentations in the last couple weeks as we prepare for Medicare open enrollment, or I guess as we're in the midst of Medicare open enrollment. Are there issues or questions that seem to come up a lot when you're out doing these presentations that you think, you would say here are highlights of information folks on the phone might want to know or be aware of?
Well, definitely people who are interested in how the marketplace plans are working with Medicare comes up frequently. Also, some of the things that we try to share with people regarding any changes that were taking place for 2015. Medicare recently recontracted the QIO network, that's the Quality Improvement Organization network for the entire nation. So for most states, the entity that was your QIO has changed. And the QIO, by the way, is the people that, if you've got someone who is a Medicare beneficiary and they're receiving treatment that is being paid for by Medicare and you don't feel that the quality of care that they're receiving is what it should be, then the QIO is who you would call to have them review that care. Also, for any of your clients that are in the hospital, and if Medicare is the entity that's paying for that care, if if the hospital comes in today and says, well, we're going to discharge you tomorrow, and the beneficiary feels like that's too soon, they can call the QIO and request an appeal. And the QIO will come in and they will do a review. It usually takes about 24 hours. And if they agree that they're sending you home too soon, then you can actually stay in the hospital. So it's very important to identify who the QIO is in your state. In Oklahoma, it changed from the Oklahoma Foundation for Medical Quality to an organization that's called KEPRO, and KEPRO is actually out of Ohio. So if you just Google the Quality Improvement Organization, you will come up with a list of who the QIOs in each of the states are and their contact information.
Thanks, Ray, for that information. We actually have a question. The question is asking, are the formularies listed at the point of sale through the Medicare or through hospitals? And how do you look for these?
You can go on. You can actually go on to the individual plan's website. Like if you wanted to look at the Humana plan or something like that, and you could see the formulary for that plan. The tool that I recommend that everyone use, and this is the exact same tool that we use as counselors, go to the website medicare.gov. And on that website, there's a button that's toward the left-hand side of the screen that says Find Health and Drug Plans. And that will take you to the tool that's called Plan Finder. And this is actually operated by CMS. And you can use this tool to identify what are the drug plans that are available in your area. And you can actually, once you get to the page with those drug plans, you can pull up what that formulary is. And how we use this tool is there's a way you can do an actual personalized search. If you've got that person's Medicare number and their date of birth and when they became effective on Medicare, all the information they ask on that first screen, you can fill in that information. Or if you just want to do a general search of what's available in your area, just put in the zip code under general search. And then you can go through and you can identify what drugs are going to be covered by which plans. And it's a very easy tool to use, by the way, and I'm happy if anyone's got any questions, if when they get in there and look at it, they can certainly call me and I'd be happy to answer any questions they may have.
Can I ask a follow-up question on that, Ray?
Sure.
It used to be when you used that plan finder, you could actually put in your medications, and then it would say, here's how much it would cost for the different plans.
Yes.
Still do it that way?
It's still, and we encourage people, it's much more useful if you take it down to that level. If you will find out from that elder what are the prescription drugs that they take and you enter all of that information into the system, it's going to give you a much clearer picture of what that individual's costs are going to be for the coming year, because it's going to tell you what their monthly premium is going to be, and it will tell you down to the individual drug how much their copays will be for those medications. Not only at that level, but nowadays a lot of these plans are contracting with specific pharmacies. So sometimes people can save a lot of money by using, say, a Walgreens pharmacy versus a Walmart pharmacy or vice versa. So the more detail you can put into the system, the much more useful information you're going to be able to generate for your clients.
We were actually able, I use that almost every year with my grandmother, and we put in her medications and stuff, and because of using that, we've seen like the costs differ, and she's actually switched her Part D plans almost every year for the last, 3 or 4 years. She's somebody who falls into the donut hole around August or September. But, knowing that information in advance, she was able to make those decisions based exactly on the medications that she uses. So,
yeah, the premiums not only change in the copays, but as you said, the drugs that the individual is taking change also. So it's very important to do that review every year.
Yep.
If there are any other questions, please feel free to write them into the Q&A pod. And while we're waiting for other questions, I also wanted to mention that there is an evaluation survey that we would love for you to fill out in order to help us in creating new opportunities for webinars and topics that are important to you and that will be helpful to your programs. There is a link in the chat pod for our SurveyMonkey link, but you'll also receive this link in the follow-up email. If you could just take 2 or 3 minutes to fill out that survey, we'd greatly appreciate it.
And I will just say, but as folks are starting to drop off, there are more slides that go on. So when you get the full slide deck, there will be more information in there. It'll talk about appeals and rights and the different plans, and there's a nice graphic that talks about the appeals process, which from the center level, at the clinic level, you actually may be engaged in the appeals process for medications and those types of things. There is an acknowledgement. A lot of this information is based on the CMS National Training Program, so there's a link to that. There is a resource guide with some links to information, resources, and products. Ray was kind enough to put together a slide that shows the standard drug benefits and the changes. That's an appendix slide. Also, some income limits for extra help, which is part of Part D. Some MSP, the Medicare Savings Program, income and resource limits are there. And I think that's it. So once you get the full slide deck, be sure to flip through that last bit so that you can see the additional slides and resource information that are there.
Well, I'd just like once again to thank you, Jolie and Ray, for all of the information that you provided here today. I'm glad that you were able to come back and present a second webinar for us so that we could fully touch on all of the information around Medicare. I'm hoping that people will be able to access the slides once they're received and go through the webinar once again if there was any information that they were unable to hear at this time. It's now about 4:30. We're at the bottom well, the middle of the hour, I should say. And so I just like to once again ask you all if you're able to fill out our evaluation. We greatly appreciate it. And with that, I'd like to end the webinar if there are no other questions that come in the next minute or so.
And thank you from IA Squared, and I'm sure Ray Census thinks as well. And I appreciate his participation today as part of our project for the Senior Medicare Patrol Program. So let us know if we can help or offer any assistance following the call.
Also, I meant to tell you, if anyone does need to send me a question, because I know we covered a vast amount. The information that we covered today is probably something that I usually do in an all-day seminar, so I apologize if it was very quick. If you do have some questions that you think of after the call, my email address is ray, R-A-Y, .walker, W-A-L-K-E-R, at oid.ok.gov. And feel free to send me any questions you've got. I'd be happy to help you.
All right, thank you all for joining in on this webinar.